Hi everyone, this is John Mandrola from the Heart.org Medscape Cardiology, and this is This Week in Cardiology for September 15th, 2017. This week, I'm talking PFO closure, hormone replacement therapy, dual antiplatelet therapy, obesity, and fentanyl. First up, the New England Journal of Medicine this week published 3 studies and 2 editorials on the matter of PFO closure in patients with stroke of undetermined origin. Now, all 3 of these trials went in the direction of favoring PFO closure, albeit with the small absolute risk reductions and increases in device-related complications and higher rates of AFib in the device arm. In 2016, the FDA approved the Amplatzer PFO occluder device. For me, the most compelling of the studies was the closed trial, which randomized patients with large atrial septal aneurysms or large shunts in the atrium to either a device, antiplatelets, or anticoagulation. The groups were then analyzed in two ways, device versus antiplatelets, and then antiplatelets versus anticoagulation. The study found 0 strokes in the PFO closure group and 14 in the antiplatelet arm. The antiplatelet versus anticoagulation comparison arm was underpowered, but it showed no major differences. The RESPECT trial, this is the second of the trials, had been previously published in the device versus medical therapy, and now all sorts of medical therapy. That includes antiplatelets, anticoagulation, dipyramidol. This showed a trend for lower stroke rates in the device arm. The long-term results, which was published this week, favored the device, 0.58 event rates per 100 patient years in the device versus 1 per 100 patient years in the medical therapy arm. So again, significant statistically, but small reductions. And in this multinational REDUCE trial, this is the third trial, 2 types of occluders were studied, and they were used in combination with aspirin, so aspirin plus device versus aspirin alone. And again, this trial turned in favor of the device significantly, 1.4% versus 5.4%. Now, the REDUCE trial, this third trial, also used pre- and post-MRI scans, which showed fewer infarctions in the device arm, but the incidence of silent brain lesions did not differ between the groups. These 3 trials are all concordant with each other. There were benefits, there were harms from the device, and what's weird is that this data is a reversal from the previously negative data. And I don't know what to think about that yet. I need to do more work looking into these trials. I do know that the real experiment we need today in 2017 is to test the occluder against a direct-acting oral anticoagulant agent. This is no knock on the trialist. I mean, we didn't have DOACs when these trials were started. The next topic is hormone therapy in women. Now, one of medicine's biggest reversals was hormone replacement therapy for cardiovascular protection. Younger women had lower rates of MI, perhaps due to the effects of estrogen. And in observational trials, hormone replacement therapy associated with lower rates of CV events. So doctors began to prescribe hormone replacement therapy to protect women from heart disease. Well, then came the RCTs, primarily the WHI studies, Women's Health Initiative studies, and it showed that this strategy did not prevent heart disease. One of the WHI studies was stopped early because of increased risk of breast cancer. The other was stopped early because of an increased risk of stroke in the HRT arm. However, a new analysis published in JAMA from the original authors, one that includes a massive 18 years of follow-up, found no difference in all-cause cardiovascular or cancer mortality. Now that's remarkable, this neutral effect, because none of the WHI trials were intended to assess benefits on menopausal symptoms. So the clinical relevance is, I think we can now say that if HRT is used for symptom control, there's strong evidence that it does not worsen overall death rates. Now, this is especially true in younger women. Remember, the mean age of women enrolled in the Women's Heart Initiative was 62 to 63 years. I suspect, I don't know, but I suspect that if we looked at younger women, HRT therapy would be even safer. Third topic today is dual antiplatelet guidelines, or DAPT guidelines. Now, I'm forever walking down the hall to the cubby of the interventionist. Yes, we have cubbies here in private practice. The reason I go down the hall is to ask about dual antiplatelet therapy. Usually it's duration. At the ESC meeting, the European Society of Cardiology issued a new focused update on its guidelines on dual antiplatelet therapy. And this update contains a major change, a concept change, from the previous recommendations. Now, the writers focus much more on personalized medicine, especially focusing on an individual's bleeding risk. They recommend use of the precise DAPT score, and this score takes into account the age, cigarette smoking, diabetes, the type of presentation, whether prior PCI, the type of stent, presence of heart failure. But the most novel and important message here is that the DAPT therapy is a regimen to treat a patient, not the previously implanted stent. Now, some brief specifics. For instance, for ACS, guideline writers recommend dual antiplatelet therapy for 12 months, regardless of the revascularization strategy. And 6 months of DAPT should be considered if there is a high bleeding risk. Another specific, the need for short-term dual antiplatelet therapy should be guided by assessment of the individual's bleeding risk, not by this type of stent. On another one, adding dual antiplatelet therapy to oral anticoagulation increases the risk of bleeding 2 to 3-fold. And so they recommend that the indication for anticoagulation should be revisited and anticoagulation continued only in this case with compelling reasons. They also recommend that dual antiplatelet therapy plus oral anticoagulation should be limited to 6 months. Finally, I downloaded the Pocket app from ESC and I find it pretty useful. Fourth topic today, obesity. Yet another major population study confirms the obvious fact that obesity delivers an elevated risk for coronary heart disease, stroke, and heart failure, especially heart failure. Now, this most recent analysis, published in JACC from UK authors, is the largest study to date and includes almost 3.5 million people who had more than 165,000 outcome events. The authors split the group in 4 weight categories: underweight, normal, overweight, and obesity based on BMI. To measure metabolic health, they use glucose, blood pressure, lipids, and the main finding is that obesity, even without any metabolic abnormalities, associates with a higher risk of coronary heart disease events, 1.49, stroke, 1.07, and heart failure, 1.96, compared with normal weight and no metabolic risk factor patients. In the discussion section, the authors give reasons why their paper is more robust than the previous studies, which also show similar findings. And again, the take-home, I believe, is that obesity needs to be considered a major risk factor in and of itself. And the notion that having normal sugar, blood pressure, and lipids can negate the risk of obesity needs to be discredited, both at the bedside, but also by leadership in preventive medicine circles. Finally, a really cool study that I'll close with concerns the use of fentanyl in the cath lab. Now, almost all the patients who come to our cath lab with ACS receive sedation, usually with midazolam and fentanyl. Now, the problem, fentanyl reduces the antiplatelet effects of the drug ticagrelor. Now, these were the top-line results of a single-center RCT from Johns Hopkins. It was presented in abstract form at ESC. The study was called PACIFY, P-A-C-I-F-Y, and it had 212 patients. Half of them got fentanyl and half of them without fentanyl. And the investigators then measured platelet function and the concentration of ticagrelor at 30 minutes, 1, 2, 4, and 24 hours. And the plasma concentration of ticagrelor was higher in the no fentanyl arm. In other words, fentanyl reduced the concentration of the drug. They also found clinically significant differences in platelet reactivity in the two groups, namely higher percentage of patients had platelet function in the fentanyl arm. Now, fentanyl is short-acting, so it's not surprising that the differences stabilized by 4 hours. So it's hard to know the clinical implications of having higher platelet function in those first 2 to 3 hours. But stent thrombosis is certainly high risk right after the procedure. This is a nice study. It highlights a specifically relevant topic. It confirms previous studies that showed morphine reduces antiplatelet actions, and it really underscores the importance of understanding and knowing about pharmacology. I see this time and time again in clinical practice, and that is bad outcomes occurring because of unrecognized drug-drug interactions. So that's it for this week in cardiology. I'm really grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape Cardiology. See you next week.